Ladies and gentlemen, as a VR surgeons, we all come across this kind of a situation which I'm going to speak about now, and I'll be showing a few videos. Vitrectomy in complicated cataract surgery, fortunately, is not very common. However, it is there and we need to know how to deal with it. Starting with the most commonest thing which we come across is the nuclear drop, which can be a fragment or a full nucleus itself, or it could be a complete nuclear capsular complex and or significant SLM, the soft lens matter. What are the indications for removing those? Certainly we all agree that if there's a full thick nucleus, it has to be removed. Large nuclear fragments which will stay in the eye and would not absorb on their own. Persistent posterior segment inflammation, certainly an indication for vitrectomy. Uncontrolled secondary glaucoma, which is not controlled by normal medication and is being persistent, requires vitrectomy, especially when there is a nuclear chunk present. And significant non-absorbing soft lens matter, which is blocking the visual axis, certainly requires surgery if it is not absorbed in time. What are the principles we follow? Certainly for removal of the fragments, it's important that we should have a thorough vitrectomy, including the induction of PVD, before removing the nucleus in order to reduce the traction. And also the vitreous cutters are quite efficient to remove with high vacuum and low cut rate. Fragmentome nowadays are not used, however, one has to keep them in case you come across a very, very dense cataract. Heavy liquid cushion to the posterior pole is always a good idea to protect the posterior pole, and also sometimes to float the nuclear fragment up in case it's a very thick nucleus and patient is aphakic and the cutter is not removing it. The pearls is the same, the complete removal of the nucleus or the nuclear fragment, clearing the visual axis, and implantation of the IOL either in the sulcus or scleral fixated to restore the vision. Can you play the video, please? So this is a video of you can see a full nucleus which is dropped right at the bottom, sitting on the posterior pole. And I normally start with, after the induction of the PVD, the core vitrectomy, and I'm quite keen to remove the complete vitreous. Shaving, I think, is important, especially in some cases where there is some vitreous hemorrhage, and I normally employ retroillumination to go to the vitreous base and completely remove it. And once the shaving is done, I always then proceed for the posterior pole cushion with the heavy liquid, and then removal of the nuclear fragment. 23 gauge in my hand, I think, is pretty efficient. And normally I grab it with the edge and then start the vitrectomy. And then, as Felipe mentioned, the crush technique. So you hold the nucleus, crush it into pieces, and then you just have to be patient, and ultimately you remove all the nucleus safely and efficiently. Moving on to the next complicated situation, which I've recently come across, where there was a cataract surgery performed elsewhere with the posterior capsular tear and then resulted in detachment next day. Can I have the videos, please? And this, you can see there's an extensive soft lens matter already present, although the IOL has been placed. So it's important to clear the visual axis before you proceed for the detachment surgery and treat it as normal retinal detachment. Here you can see there's a vitreous hemorrhage as well, indicating a bit of a trauma, surgical trauma previously, and a bullous detachment. However, we need to continue as a normal retinal detachment surgery. After removing the core vitreous, I proceed normally to the periphery to do the vitreous base shaving as much as efficiently we can do, and then proceed to find the hole and drain the fluid from the hole, as you can see in the supratemporal quadrant in this case. And once the retina settles down, finish the vitrectomy, the vitreous base shave, and then followed by air fluid exchange, removal of the soft lens, and then the laser to the breaks. So in these kind of situations, the challenges we come across is very hazy media, soft lens matter presence, high intraocular pressure, posterior segment, persistent inflammation, and it can be a challenging situation. And then the PCIOL would be unstable because the recent surgery has been done and the capsular support is not great. Vitreous hemorrhage compounding the problem, and least but not the the retinal detachment. In this kind of a situation, don't be hesitant to remove the epithelium because normally the corneal epithelium would be hazy due to the high pressure. Remove the SLM from the anterior segment and behind the lens to clear your view, and thorough vitrectomy with indented peripheral shaving. It's important to completely remove the blood-stained gel, so I'm quite keen to remove the peripheral vitreous. And however, gentle indentation required because a PCIUL can be dislodged. And chandelier light is must if there's no assistant. And now this is the last scenario which I've come across a few years ago while when I was a consultant in UK and one of my residents were doing a cataract surgery. Can we play the video, please? And after removal, straightforward surgery, after removal of the cataract, he realized that the pressure in the eye has suddenly gone up. The eye has become very hard, as you can see. He's trying to inject the viscoelastic to deepen the AC, but everything is coming out. So I was called in. I looked through the indirect to rule out any suprachoroidal hemorrhage or expulsive hemorrhage. Luckily, there was none. However, the eye was very hard. So I proceeded with one port anterior vitreous face debulking. And then you can see that straight away the eye became soft. We were able to inject the intraocular lens safely. And then looked about in the anterior segment, and there was a vitreous tug coming at about 11 o'clock position, which was removed with the scissors, and then the procedure finished. Basically, in this kind of a situation, there was a aqueous, or not aqueous, but BSS misdirection because there was a pre-existing zonular dehiscence which was not noted before. So in this kind, you need to make sure at this time, at that point of time, that there is no sign of expulsive hemorrhage, and single port vitrectomy quickly debulks the anterior highlight face, and it's very efficient with 23 gauge. Now, the most important thing to note is that if you come across any patient with the axial length more than 22 or higher than 26, be a little prepared. Always do a gonioscopy in clinically mid-depth or shallow AC to look for signs of phacogenesis. And if you see some, then always be prepared. I would suggest preoperative Diamox 500 milligram either orally or intravenously 2 hours prior to the surgery. So basically, we can achieve good results with careful preoperative planning. But in my opinion, in these kind of situations, timing of the surgery is the key. Not too soon, not too early, but the optimal timing. And that's the key to success. Thank you very much. And as Felipe would know, this building, where we were trained together, and always a special place in my heart. Thank you very much.